welcome everybody kind of on behalf of the Advances in Behavioral Health Policy seminar. And so kind of excited this year to be kind of collaborating with Marisa and kind of alternating some international talks and domestic talks. And so this is our first kind of global one. And so I'm thrilled to have Dr. Siham Sikander be our speaker. And Dr. Sikander, for as you don't know, he's trained as a psychiatrist and as a researcher. So is able to kind of, walk both worlds. He has multiple appointments. He's a senior research associate at the University of Liverpool, principal scientist and mental health advisor at the Human Development Research Foundation and in Pakistan, and also faculty. He's on the faculty of the Health Services Academy in Islamabad. And so he's quite spread around, going back and forth between the UK and Pakistan. So he stays quite busy. And his work focuses a lot on designing and evaluating mental health. So mostly maternal mental health interventions that are, scalable, delivered through existing systems and in the community. And that's how it all kind of connects to, community health workers and peer delivery. And yeah, thank you, Siham, for sharing your work with us today.
Thank you very much, Asha, and good evening, good afternoon, and good morning, everyone. Thank you, Asha, for giving me this opportunity to actually present our collaborative work, the kinds of things that we are trying to do in a low resource setting, which is Pakistan. So what I will be doing in the next 40 to 45 minutes is to try and set some context, both in terms of many of you might not be aware about the Pakistan and its context, what the general maternal mental health scenario of the country looks like, and what are the mental health resources, the specialist resources, what are the perspectives and how this all context is set up. Then I will try and move into more the task shifting approaches that we've been developing and we've been testing. What has the evidence been so far, and the kind of challenges that we are also seeing. Like Asha said, that we, from the outset, the aim is to have something which is scalable. So how are these challenges being piled up as we move forwards and generating evidence? Then, as a social innovation, I like to think of it as a social innovation of using peers as a task shifting agenda and pushing this further into the communities. So I will talk about that. And I will give you a snapshot of what the evidence is now coming up in terms of how effective these peers are within the community settings in addressing maternal mental health. And what are the kinds of lessons that we are drawing up from a longitudinal study, a cohort study, which we call the Bachpan cohort. Bachpan is an Urdu word. Urdu is the local language of Pakistan, and it means childhood. So I'll give you a brief snapshot of what this cohort is and how is this informing us into what the implications so far are and what we think is the potential way forwards. So let's look at Pakistan in a glance. So Pakistan being the sixth most populous country of the world, we are 224 million in terms of our population size. We don't rank and fare well in terms of human development. We're at the 154th position out of 189 countries. Our fertility rate is highest amongst the South Asian region. Our life expectancy is just barely crossed 65 years across both the males and females. We still remain quite an uneducated population. As you can see, just about 4 years of education for women. The government spends just under 3% of the GDP in terms of health expenditures. We've been, since the last 20 years, trying to address our maternal mortality rates. It's gone down. Still, this is one of the burdens that we are still tackling, with some portions or some provinces of the country still having around 230 deaths per 100,000. Child mortality very gradually is slipping down, but it still is in the under 5. It's nearly 63 per 1,000 live births, and under 1, it's still around the 53 per 1,000. We have a staggering burden of stunting under 5 of nearly 40%. This has been there since the last 10 years, and it's just not moving. So that's what Pakistan looks like in terms of a snapshot. So how, in this context, if I were to give you an overview of the general mental health well-being of women in Pakistan, so some systematic reviews and recent community-based larger studies have indicated, along with the demographic health survey, that there's a substantial proportion of women, adult women, who experience common mental disorders, especially depression, so around 35%. A sizable half of the studies have shown that nearly 50% or more experience intimate partner violence. 1/3 only disclose. Many studies indicate that the odds increase of having suicidal ideation, secondary to physical and psychological violence. So the literature is now just beginning to indicate that there is a burden of intimate partner violence as well. Surprisingly, our demographic health survey also indicates that up to 12% of women do experience violence during pregnancy. So in this context of an overall mental health being poor of adult women, what happens if this coincides with their childbearing cycle? So now what's known as perinatal depression or maternal depression. So depression during the pregnancy period till the first postnatal year, or even in some cases beyond the first postnatal year, which is usually referred to as maternal depression. So two systematic reviews done to see the burden and prevalence and estimated prevalence of perinatal depression across the globe puts Pakistan in one of the highest prevalent countries of the world. So nearly 31% of women experiencing perinatal depression. Our previous set of studies, our group's work around perinatal and maternal depression, does indicate that there are numerous risk factors. This perinatal depression, which begins during pregnancy, seems to sustain during the first postnatal year. Conflicts within the family, marital conflicts, financial issues seem to be the risk factors. Lack of social support has also been featured as one of the risk factors for perinatal depression, and high rates of this in Pakistan. Pakistan also seems to have a preference for male gendered children. So boys are a well sought after thing, and women who don't bear sons seem to be at a higher risk of perinatal depression. One starts wondering, what impact does this carry? So it carries impact on the moms themselves, obviously. This can lead to suicidal ideations and potential suicide, not to mention the decreased productivity, the poor social functioning, the negative cognitions, but it also has long-term effects on the child, starting from, actually, if you look at any of the child health indicators, beginning from low birth weight, malnutrition, stunting, as well as poor cognitive, social emotional development. So all these key indicators seem to get affected by perinatal or maternal depression. In many of my talks, I like to present this Neil Halfin and colleagues very nice graph, which depicts the health, development, and life course trajectory of children starting from infancy to under 5 years of age. So these trajectories, if you look at these, there are some arrows, what I like to call as the downward forces, which keep pushing the trajectory towards the red line, which is the poor health trajectory of children. So if you look closely, this toxic stress in the form of maternal depression, internally displacement, so children's environment, what kinds of toxic stress in terms of maternal depression can keep pushing this trajectory towards the poorer health outcomes. Not to mention lack of health services and poverty also are downward forces or variables to bring the health trajectories towards suboptimal outcomes. No wonder that maternal depression has been labeled as a global threat to child development across the globe. So with this context of maternal depression and its impact, so one would start imagining what are the specialist human resources? How is Pakistan dealing with this? So what are the perspectives around the specialist care? Like many other low resource settings, Pakistan also has a scarcity of mental health specialists. Like anywhere in the world, majority of people, majority of the population lives in that part of the globe where there is less than one psychiatrist per 200,000 people. Pakistan is no exception. So you'd be surprised. Like Asha said, that I am a psychiatrist. I come from a background of psychiatry. So including me, 2019's count was 375 psychiatrists for a population of 224 million. You can add around 500 psychologists to this 375 psychiatrists. So we still are less than 1,000 specialists. We don't have psychiatric nurses, we don't have social workers. So the treatment gap is tremendous. And these 375 psychiatrists plus 500 or so psychologists, less than 1,000 people, they settle and they work in the metropolitan cities, while still 70% of our population in Pakistan is rural based. So there's a huge treatment gap. Not unlikely in the high income country settings, what the evidence suggests is around 50 or plus % of treatment gap. Whereas in Pakistan, especially for maternal depression, it's more than 95%. So we don't have the resources. We will never have enough specialized human resource to address maternal mental health, let alone other mental health issues. So how do you bridge this treatment gap for maternal depression? Can we task shift? Can we task shift through non-specialists? In a single sentence, yes, we can very successfully task shift. So that's a huge way forward. With such a big burden, knowing that we can task shift, we can successfully task shift. We've done that in Pakistan back in 2000 and early in the 2000s. Atif Rahman developed a psychosocial task shifted intervention, community-based, delivered through lady health workers. Lady health workers are government employed community health workers. They are based in the villages. They serve the population, preventive and promotive services for mother and the child, mostly around family planning and antenatal visits and postnatal care. So this Thinking Healthy program was designed and developed for delivery through these community health workers, the lady health workers. It showed evidence. I will come to that. And back in 2015, this was taken up by the WHO as one of its global mental health intervention guide interventions, low intensity psychosocial interventions for global dissemination. This intervention was tested in a randomized trial in Pakistan and showed good effect sizes, and I'll come to that. So what is this psychosocial intervention Thinking Healthy program? It's basically a psychological intervention. It's watered down in terms of easy understandability by a community health worker who's a trained professional, comes from a health system background, but is simplified. The principles of cognitive behavioral therapy are simplified. It's a very structured, manualized intervention. Has a brief training period with ongoing supervision to help experiential learning. It has a good component of family engagement to harness support for women who are distressed and are have maternal depression. So in Pakistan, lady health workers, the community health workers were trained by psychiatrists, supervised by psychiatrists. They were sent to deliver these interventions, a face-to-face, household-based intervention through the lady health workers within the community settings. And what we saw compared to other perinatal depression interventions, psychosocial interventions within the LIMIC settings, Thinking Healthy program showed the largest effect size. And this was one of the reasons that it was taken up by the WHO for global dissemination. So we were very happy, extremely happy. Aha, so the burden will at last be dealt with. But then the elephant, may I say elephants in the room of scaling up evidence-based interventions in any low resource setting, let alone Pakistan, it's riddled. Psychiatrists training lady health workers. If I give you a little bit of a context, we have around 1,500 lady health workers spread across Pakistan. So how many psychiatrists will you need? So that's not a sustainable way. Not to mention this one of the elephants in the room of scaling up as a barrier is weak health systems and overburdened health systems. So these community health workers, which I keep referring to as lady health workers in Pakistan, they are a finite resource. They cover nearly 85% of the rural population. They originally were designed for family planning at the moment, and they were launched back in mid-80s through Benazir Bhutto when she was the prime minister. And this was primarily launched for family planning services and providing some antenatal support and postnatal care. At the moment, these lady health workers are mandated to carry out 22 different duties apart from family planning. So if I were to ask them, that add Thinking Healthy program sessions within your 22 other mandatory stipulated duties. So they will not be able to deliver this. So that's one of the elephants in the room. And while once I was coming back from the field and I saw this overburdened truck, at the first glance, I couldn't understand what this was. I just could see just two sacks stacked upon each other, and it was moving. And I asked my person who was driving the vehicle, I asked him, Hanif, quickly, I want to see what's in front of this huge thing, because I was really intrigued. And to my surprise, it was a truck. And that day, it just made me think about lady health workers. They are already overburdened like this truck, bent out of shape. So Thinking Healthy program cannot be scaled up through the existing structures. So back in 2012, how NIH launched through the National Institute of Mental Health, launched a funding opportunity where they funded global hubs across the world. And one of these hubs was collaborative hubs, was the South Asian hub, which was led by Atif Rahman and Vikram Patel. And this hub was specifically tasked to look at and find out challenges of scaling up task-shifted interventions. So we thought that this was a brilliant opportunity where we could potentially think beyond the lady health workers, beyond the community health workers, to try and push the boundaries of task shifting further down into the communities and use peers. So this global, one of the global hubs, the South Asian hub, was tasked to adapt and test out an intervention, deliver the Thinking Healthy program, the WHO's Thinking Healthy program, delivered through peers. So we did some adaptations, and I can circle back what adaptations were these. Essentially, a cascaded model of training so that a psychiatrist need not to train. Can that be feasible? Can that be effective? And since these are peers, lay peers from the community settings, so for them to be able to understand, so we slightly watered down the content as well. And during that South Asian hub, this was tested in two diverse settings, in India and in Pakistan, and I'll come back to that. One was urban and one was rural, so we did some peer work across the two diverse settings. While this was happening, while this global hub, one of the global hubs in the South Asian context was getting ready to adapt and test out this peer-led intervention, the funding from the Institute of Child Health and Human Development, led by Asha, gave us a brilliant opportunity to expand that trial participants into more of a pregnancy birth cohort, which we ended up calling the Bachpan cohort. So apart from the trial, we expanded the trial into a cohort, added a reference group of non-depressed women, also extended the intervention, the peer-delivered intervention, which was supposed to have ended at 6 months postnatal. We thought, let's extend this further into the postnatal period, getting informed from our other studies. So Bachpan cohort got developed and established with the peers delivering a longer duration, a longer term intervention. So we were able to leverage the trial to develop and establish a birth cohort. So the Bachpan team is truly a global team spread across 4 to 5 continents. So we have colleagues from US, from UK, from Switzerland, from Australia, and of course from Pakistan. So And we continue to follow the Bachpan cohort mother and children diets. In a snapshot, the Bachpan cohort has been going on since 2014, right adjacent to the trial. And there was this intervention that was delivered through the peers during the pregnancy through to the 5 years postnatal period. And we've been using the same peers to deliver this intervention. It's still ongoing. We've just had our 3 years findings published. I will come to that. We have some extra funding to keep following this cohort till 8 years of child's age. We intend to keep extending this and seeing what we can extract and understand from this ongoing cohort, which had a psychosocial peer-delivered intervention alongside delivered to depressed women. Right. So coming back to peers and what this means and extending the boundaries of task shifting further into the communities. Asha, do we want to take a break if there are some questions being stacked up?
So I don't see any questions in the chat, but
Right.
Does anybody have any questions at this point before we shift into the peers? Any yeah, this is a good moment. Otherwise, we can keep going. All right, and if people have questions, you can type them in the chat also at any time, and I can present them as well. So yeah, so I think we can keep going.
Great. So in the next 10 minutes, I'll try and, or less than 10 minutes, I'll try and unpack our experience of working with peers. So who are these peers? So we did lots of formative work to try and understand if we were to use other mothers from the same communities, what will be acceptable to these families and households. So we did lots of research, and we understood that all the women and the women who were depressed